Our next speaker is Professor Avi Ohry, Professor Emeritus of Rehabilitation Medicine at Tel Aviv University and Reut Rehabilitation and Medical Center, and currently Medical Advisor and Director of Rehabilitation Medicine at Reut Medical Center. In addition to rehabilitation, Professor Ohry is interested in many other areas of medicine and health, among them ethics, history of medicine, medicine in the Holocaust, and others. The title of his presentation is Premature Aging Among Young People with Disabilities. Professor Ohry.
Good morning. Thank you for the invitation. I'm a clinician, not a scientist, and I want to dedicate this presentation to my British teachers in spinal injuries at Stoke Mandeville Hospital in Buckinghamshire, Sir Ludwig Gutmann, Dr. Hans Frankel, Dr. John Silver, Mr. Isaac Nusseibeh, and Mr. Wagi El-Masri. I also wish to express my appreciation to Dr. Richard Horton, the editor of The Lancet, who appointed me as member of the Lancet Commission on Holocaust and Medicine, which is at work now, really in these days. Okay, Dr. Heikkinen from the WHO said that aging is an integral natural part of life. The way in which we grow old and experience this process, our health and functional ability all depends not only on our genetic makeup, but also on what we have done during our lives, on what sort of things we have encountered in the course of our lifetime, and how and where we have lived our lives. Aging is generally characterized by the declining ability to respond to stress, increasing homeostatic imbalance, and increased risk of disease. I want to start with Claude Bernard, who taught us that the primary condition for freedom and independence of existence is the stability of the milieu intérieur, or the internal environment. The mechanism which allows of this is that which ensures the milieu intérieur, that maintenance of all the conditions necessary to the life of the element. In 1915, Walter Cannon coined the term fight or flight, and he developed the concept of homeostasis and popularized it in the book, The Wisdom of the Body, published in 1932. Then Professor Johannes Judah Grun, I met him personally in 1974 in Leiden, and he dealt with psychophysiological or psychosomatics, a disorder in which the physical symptoms are caused or exacerbated by the psychological factors such as migraine, headache, lower back pain, irritable bowel syndrome, and more. And finally, Hans Selye, that in 1936 coined the general adaptation syndrome or the stress syndrome. Okay, what are the characteristics of normal and premature aging? First of all, physiological modification, changing role in family and society circles, different self-realization, medical, functional, socioeconomic support problems. Rate of decline depends on genetics, lifestyle, and general state of health. What are the main issues in premature aging in my point of view as a clinician, as a rehabilitation physician? At first, permanent stable disabilities. We are dealing in this lecture in this kind of disabilities versus progressive condition, which is of course completely different. I deal with the young disabled patient who is aging versus the old disabled, which is not the topic of this presentation. Long-term wear and tear changes, and it's the premature aging also exists in maybe amazingly in non-physically challenged person. like blind people, we shall see it in a minute, and PTSD patients. What are the main issues? At first, again, as a rehabilitation physician, primary, secondary, and tertiary complication. Very difficult to control this. Then we are aware of the fact that homeostasis is constantly changed in these people. Then allostasis mechanism is present, and maybe the common denominator is hypoactivity. What is allostasis? When I was a student, this term didn't exist, but today we know that this is a concept which deals with the ability to maintain stability through changes. It is a fundamental process through which organism actively adjusts to both predictable and unpredictable events. These concepts enable to differentiate the needs for keeping homeostasis during normal life history versus special life situation such as chronic disability. Lifestyle-related diseases, including cancer, cardiovascular disease, and are also characterized as aging-related diseases, where aging may be the most potent causal factor. In light of this, prevention of lifestyle-related disease will depend on slowing the aging process and avoiding the clinical appearance of these diseases. We classify in the modern way the classification of disabilities in this way. First of all, neurological, spinal cord injury, traumatic brain injury, cerebral vascular accidents, cerebral palsy, and poliomyelitis. Then orthopedic, mainly amputation of limbs, and rheumatological diseases. The third area is mental and behavioral diseases, and combination of this. I will not going to read all this, but just in case of spinal cord injury patients, paraplegics and tetraplegics, you can see there are many ways, many routes that enhance the premature aging and premature morbidity. Just for example, immobilization because of the paralysis leads to osteoporosis, this leads to hypercalcemia, this leads to hypercalciuria, renal changes, hypertension, etc., etc. Or inactivity itself to obesity, hypertension, cardiovascular problems. So you can see that in every, I think in the public thinks that paralysis is just a stable, unchanging situation, but it's not. It's all the time, decade by decade, progressive, deteriorating problems, and we are ought to prevent or to slow down the premature aging processes. In traumatic brain injury, for instance, you can see that epilepsy, hydrocephalus, dementia can occur in every stage in their life, drug addiction, any kind of drug, depression, post-traumatic stress disorder, sometimes even malingering, overlay syndromes, conversion reaction. They are prone to social isolation, false obesity, hypertension, etc. We conducted in this university along many years, almost 20 years of continuous effort to finish this study. And in Israel, it's fantastic. We can conduct this because Israel is small, and accessibility to every patient to arrive into hospital or sports center. So we examined all the traumatic people with traumatic blindness. All of them were injured in a combat situation. There are about 100 of them, and we proved that the prevalence of coronary artery disease among individuals with traumatic blindness is 3 times higher than among their siblings and generally Israeli population, and twice that individuals who are blind due to retinitis pigmentosa. I didn't find any similar study like that in the literature. However, the rates of the social, demographic, behavioral, and biomedical coronary heart disease risk factor in individuals with traumatic blindness were either similar or lower compared to the control groups. It appears from our findings that traumatic blindness are a relatively high coronary artery disease risk despite lack of obvious social, demographic, and biomedical risk factor underlying their high coronary artery disease morbidity rate. The only variable that was significantly associated with coronary disease prevalence was the cause of blindness, namely sudden traumatic blindness in war. About limb amputation, my group and other groups at Tel HaShomer Hospital proved that people with traumatic limb amputation are susceptible to ischemic heart disease, diabetes, and metabolic syndrome. There are other groups in Finland and in the States that prove more or less the same. So, in mental retardation, many studies around the world, mortality is higher because it's associated with apolipoprotein E epsilon 4 in non-demented adults with Down syndrome, heart defects, leukemia, neurological and psychological complication, hygienic and nutritional negligence, and trauma due to unawareness of these people with mental retardation. About Holocaust and starvation, many groups in the States, in Israel, in England, Australia, Poland, Russia, proved the very, maybe, the very obvious, maybe, evidence that the long-term mortality after severe starvation during the siege of Leningrad or other places during World War II, people are prone to develop premature morbidity and premature aging. The one who started this disease was Auschwitz survivor himself, Dr. Leo Eittinger. He was born in Moravia in Czechoslovakia, but after the war, after he survived Auschwitz, he went to Norway, and he coined the term of the syndrome of concentration camp syndrome, and he began in the early 50s to compare the medical and psychiatric complication of concentration camp survivors to the repatriated prisoners of war, and he found a lot of similarities that these people, even 10 or 20 years after repatriation, after the end of the war, develop premature aging and premature morbidity. About PTSD, Professor Zahava Solomon in this university, I joined her group in 1991, and until now, since 1991, we follow up repatriated prisoner of war in Israel from Yom Kippur War, October 73, and we proved that this group of prisoners of war are prone to develop metabolic syndrome, shortening of telomeres, and premature morbidity and mortality. This is the publication, and just recently, this paper is just in press now, and other groups that I belong to, affiliate to, we found shorter telomeres among individuals with physical disability like poliomyelitis and spinal cord injury and PTSD patient, and it will be published in Journal of Gerontology. So the long-term consequences of disability are health problems related to normal aging complication, which were prevented along the years. Eventually they appear. Then the other consequence is the wear and tear phenomena. Those who are walked and cease to walk, or repressed pain phenomenon suddenly become a new burden to their life. And finally, exhaustion of protective psychic physiological mechanism. What we found that increased prevalence of hypertension, cardiovascular system problem, obesity, cancer, PTSD, or depression, or both. Those who worked and lived in the mainstream of life, of society, they exhibit early retirement, passivity, more sedentary life, less sports, etc. In conclusion, life expectancy increases steadily in spite of morbidity and premature aging. Maybe you can tell me why we are facing this paradox. Preventable long-term changes, confusing data in the literature, healthcare strategic changes, wellness strategies, adapted environment, long-term follow-up, and economic strategies are necessary. In Israel and in other countries in the world, it's easy to conduct these studies on disabled persons, in ex-prisoners of war, other prisoners or detainees, displaced persons, Holocaust survivors, and veterans. So the concept, if we shall adopt Lord Sherrington dogma, that maybe all these situations lead to the final common pathway, or the syndrome of premature aging or morbidities, are disabilities, trauma, disease, Holocaust survivors, torture, PTSD, captivity, and more. Thank you very much for your attention.
Thank you so much, Professor Ohry, for the very clear presentation.